Good afternoon, student. Happy New Year to all of you. So, let us start with the orthopedic. In ortho, today we will discuss about the injuries of the arm. Here is the fracture shaft humerus and the distal humerus fracture. The fracture shaft humerus is a common in adult than in the children. So peculiarities of humeral shaft fracture is it is next to the clavicle. So this is the second most common birth fracture. So remember, first is the clavicle and second is the humeral fracture. So due to the surrounding thickness muscles, then advantages are incidence of compound fracture is low and thick muscle ensure the rich periosteal blood supply and hence the fractures invariably unite. Then the malunion remain concealed within the thick musculature, so there is a no cosmetic abnormality is seen. Concealed shortening of the humerus if any, and the disadvantages are there is a widespread displacement. Then wide displacement increases the rate of the malunion. And the soft tissue interposition may occur causing non-union. So due to the ball and socket variety of shoulder joint above, malunion usually does not cause the functional disability. Gravity plays a very big role in providing a sustained longitudinal traction force to the distal fragment, and this helps not only in reduction of the fracture but also the retention. So, the shortening, if occur, largely remain unnoticed because, unlike its lower limb counterpart, the femur, it does not produce the limb and hence there is a no functional impairment. Radial nerve injury can occur before the reduction and sometimes even after the close reduction due to getting trapped in between the two fracture fragments. So this is the only fracture in the body known to show this peculiarity, that is radial nerve injury. Note the muscle forces create a malunion but also help to conceal it. Gravitational forces which provide the natural traction forces also may overdo it causing distraction or non-union. The muscles reduces the incidence of compound fracture but produce all the varieties of displacement in the common simple fractures. So, next is the anatomical consideration in which the muscles of the upper arm influence the deformity. If the fracture is in between the pectoralis major and the deltoid, the proximal fragment is adducted by the pectoralis major and teres minor and the latissimus dorsal. So while the distal fragment is pulled upward by the deltoid, and if the fracture is below the insertion of deltoid, then the proximal fragment is abducted by the deltoid, while the coracobrachialis, biceps and the triceps pull the distal fragment upward. So in this diagram, you can see this is a diagram of deforming the muscle forces in fracture humerus. So here is the insertion of deltoid and just below the insertion of deltoid there is a fracture. So in the diagram B there is a fracture just above the insertion of deltoid. So this is a deltoid muscle and depend upon that the anatomical consideration is present. Then mechanism of injury shows that direct force. So this may produce a transverse or comminuted fracture. Indirect force that it is due to fall on an outstretched hand and this will produce an oblique or spiral fracture. Birth injury, this is the second most common birth fracture after clavicle. And clinically, a careful neurological and vascular assessment is important. So, injury to the radial nerve is common in this fracture at the spiral grade or lower one third of the humerus. Then the radiographs, that is X-ray of the entire upper arm, including both the shoulder joint above and the elbow joint below, should be taken. So it helps to study the level of the pattern of the fractures. So here, during the X-ray, the shoulder joint and the elbow joint is essential to take. Then the treatment method is conservative method. This consists of the splinting the fracture if it is undisplaced. And in displaced fracture, splinting is done after close reduction, preferably under GA, that is general anesthesia. Simple splint in the birth fractures, then the simple sling may be sufficient in young children. So, this is a radiograph. This is diagram A. The radiograph showing the transverse fracture of the shaft of the humerus. That is here. Okay. In this diagram, you can see the X-ray of the transverse fracture shaft of the humerus. And this is the spiral fracture of the humerus. This is the diagram B. That is spiral fracture of the humerus. So hanging cast is useful in the older children and adolescents. Here, the gravity aid in reduction of the fracture. So they are not suitable if the level of fracture corresponds to the upper limit of the cast. And because of the forming effect of the proximal end of the cast, it is indicated in comminuted fracture of the distal third. So if the cast is too heavy, it may it may cause distraction and the consequent delayed or the non-union. So this is a diagram of method of reduction and the application of the U slab. Here is the U slab. Okay, you can see that this is a U-shaped slab for the fracture of the shaft of the humerus. And this is a counteraction, this is a traction. So while using this U slab, the fracture can be treated. A plaster of the U splint or the coaptation splint is sufficient in the most of the situation of fractures of the proximal and middle third portion of the humerus. So when there is a fracture of the middle third or the proximal and the middle third portion of the humerus, then this U slab application is indicated. So this is the diagram of the hanging cast. That this A1, this is the U slab. That is here the fracture of the humerus in the proximal one third. And this is a cast brass. So these are the different conservative treatment method in the fracture of the shaft of the humerus. So functional cast brace. These uses the muscular force in both reduce and retain the fracture. This is cast brace. This is now replacing all the other modalities of the conservative treatment and is emerging as the gold standard of non-operative methods. So hanging cast was described by Cadwell and the weight should be not exceed than the 2 pounds. So this is a hanging cast for the fracture of the humerus. Then the operative treatment are many, that is indications for the operative treatments are when failed conservative treatment, when there are multiple fracture and unstable fractures, when there is a multi-system injuries, then the radial nerve palsy after the close reduction, pathological fractures, then compound fractures with vascular injuries, segmental fractures, intra-articular extension into shoulder and elbow joint, then bilateral humeral fractures, brachial plexus injuries, and ipsilateral shoulder or the forearm fractures. So, the methods are DCP planting for the fractures at all the levels and still remain the gold standard. LDC-DCP is preferred where the radial nerve injury is concerned and intramedullary fixation at the middle third of the fracture. So there is a rigid interlocking nail is being tried recently for the segmental fractures, proximal and distal fractures. There is a pathological fractures and the polytrauma patient, etc. So when you see, you can see this radiograph and or the X-ray which is showing the humerus plating. So in this diagram you can see a plating within the humerus here. And this is a diagram B which shows the I and L humerus. So this is another type of the plating. So multiple flexible retrograde IM nailing, self-locking expandable nail are being tried and external fixation for the open fractures. So in properly indicated cases, open reduction and the rigid internal fixation with DCP plate and the screw is recommended. That here you can see this in this diagram. You can see how there is a plating and the screw is recommended when there is a multiple fractures. Then interlocking nail technique is now being more commonly used for the comminuted fractures of the humerus. That is this one. That is the interlocking INL, interlocking of the humerus. When there is a communicated fracture of the humerus, then this treatment is given. So complications here, radial nerve injury is the most common in the lower one-third fracture. So is usually of a high variety. It may also be damage in the spiral groove and close fractures needed the observation splinting of the wrist and the fingers. If a radial nerve defects occur after a close manipulation and immediate exploration is necessary. So, Sarmentio brace is a good alternative to IM nailing with the 84% success rate, and there is an interlocking nail is also useful method nowadays. So, this is a diagram of the entrapment of radial nerve. This yellow, this is a radial nerve, and here there is a fracture fragment of the humerus. So here radial nerve is entrapped in between the fracture fragments of the humerus. So it causes a radial nerve injury and it is very dangerous. Nerve-wracking facts about the radial nerve are: radial nerve is the commonest nerve to be injured in the fracture of the shaft humerus, and incidence is 2 to 18% at the middle one-third of the fracture. It recovers spontaneously by 3 to 4 months and exploration indicated beyond 3 to 4 months. So radial nerve palsy appearing after close reduction is an absolute indication for the exploration. Vascular injury to the brachial vessels is unusual and it requires a repeated assessment and the prompt treatment. Then malunion. Malunion in the humeral fractures, angular deformity at 20 degrees is acceptable in the middle and distal one third, while in the proximal one third, that is 30 degrees, is acceptable. The thick muscles in the upper arm are usually conceal the malunion. Then, do you know the acceptable levels of the malunion? It is up to the 3 centimeter shortening, 20 degree of the varus angulation and 30 degree of the anterior or the posterior angulations. So there is the non-union. Non-union is not very common but may be seen due to the overweight hanging cast, and these require a open reduction and excision of the fibrous tissue, rigid planting and the bone grafting. So interesting facts are Holstein-Lewis fracture, that is, it is a spiral fracture of the distal third wherein radial nerve is more injured. Then distal humerus fractures. In the firstly, we see the proximal humerus fracture, and then the second part, that is the distal humerus fracture. The regional anatomy shows that the distal most of the lateral column in the capitulum and distal most part of the medial column is the non-articular medial epicortex. The articular segment is formed by the trochlea medial and the capitulum, that is lateral. The trochlea forms the tie arch between lateral and the medial column, and this articular segment is tilted 40 degrees forward. So in the AP view, the articular surface make an angle of 4 to 8 degree valence to the shaft axis, and anteriorly there are the two fossa. First one, that is radial fossa, and the coronoid fossa posteriorly. So there is a olecranon fossa, and these receive the head of the radius, coronoid and olecranon process of the ulna respectively. And the incidence shows that there is the rare fracture compromises 0.5% of all the adult fractures, and individual incidence is type A, that is 10%, type B, that is less than 5%, and type C, that is 85%. 41% cases are open fractures, and age incidence is about 40 years of the age. Then mechanism of injury shows that these injuries are mainly due to the longitudinal force through the elbow that is flexed beyond 90 degrees. And the clinical feature shows that the patient present with the pain around the elbow with the gross swelling, deformity, severe loss of the elbow movement, crepitus, and the neurovascular impairment, which may be present in the forearm or the hand. And the radiograph shows that there is a good quality of the AP and lateral view of the plain X-ray are enough to make an accurate diagnosis. And the classification shows that type A, that is extra articular, type B partially articular, and type C, that is completely articular T or Y shape. So these are the diagrams. This is the diagram A, in which X-ray showing the extra-articular distal humerus fractures, that is AP view. Here you can see distal end of the fracture of the humerus. This is the AP view, and this is the lateral view. Here you can see a fracture of the distal end of the humerus. Okay. Then three types of the C variety, that is type T or Y variety. Simple articular fracture with the non-articular supracondylar area is communicative and articular segment is communicative. So in this, the X-ray showing the method of internal fixation of Why articular fracture of distal humerus? So in diagram A, here you can see this with the intra-articular communicated variety. That in diagram A, intra-articular communicated intra-articular variety. And in diagram B, you can see the reconstruction of intracondylar fracture. That by using the screw plates, internal fixation of Y intraarticular fracture of distal end of the humerus is reconstructed of the intracondylar fracture, which is seen in the X-ray in the diagram B here. So, Mehens and Mehta AF classifications are A, high T, B, that is low T, C, that is Y fracture, D, that is H fractures, and E is the medial lamellate, and F, that is lateral lamella. So, treatment of it is the goal of the treatment is to restore the anatomical configuration of the joint surface. It is the main aim of the treatment of every fracture. And non-operative treatment indications are frail and debilitated patient when there is extreme osteoporosis. Local conditions of the skin are not conducive for surgery. Then open, deglove or crush elbow. And methods used are overhead skeleton traction through the olecranon, then initial traction converted to the cast brace or the hinge. Then operative treatment shows that this is the treatment of choice in unstable distal humeral fracture, and this can be accompanied by open reduction and the rigid internal fixation with the screw or plate, and screw and 90-90 plate. So the reconstruction of the lateral and the medial column has to be done and fixed with the plate or screw with the fixation of the intra-articular segment. Open reduction and internal fixation of the distal humerus through an olecranon osteotomy approach seem to be offering being better result of late. So advantages of these are there is a reconstruct the distal humerus more accurately. It helps in early mobilization of the elbow and enable entry restoration of the elbow functions. So this is all about the injuries to the humerus. So next topic is the injuries around the elbow. Here injuries around the elbow shows a brief anatomy of elbow joint, then injuries around the elbow, supracondylar fractures, dislocation of elbow joint, radial head fracture, fracture of the olecranon, then coronal fracture, capitellum fracture, PCL fractures, and sidewise injuries. So, when you see the brief anatomy of these, elbow joint is the most notorious joint in the body. So it is associated with the many complications following injury or trauma to the elbow, and it easily becomes stiff and offers stiff resistance to the efforts of treating doctors to make it mobile again. So it is easily become a stiff and offers the stiff resistance to the effort of treating doctors that to make it mobile again. So when you see this diagram, this is the anatomy of the elbow joint. So in the extension, that is in the posterior view, you see this is the right elbow joint. Here is the humerus. This is the olecranon fossa. This is medial epicondyle, lateral epicondyle, groove for ulnar nerve. This is ulna. This is the head and neck of the radius, and this is the radial tuberosity. Then in the flexion, that is in the medial view, you can see this one is a humerus. This is a medial condyle, capitulum, and the trochlear. This is the head, neck, and the tuberosity of the radius. This is a coronoid process, trochlear notch, and the olecranon fossa of the ulna. And in the extension, in the medial view, you can see this is a humerus, this is radius, and this one is a ulna. So, elbow joint is a compound paracondyle joint as in the lower end of the humerus which articulate with both the radius and the ulna. However, it is the hinge joint allowing only flexion and extension through an arc of 150 degrees. So more specifically, the humero-ulnar component of it is a modified stellar joint and the humero-radial component is unmodified, which is over. So here is the humerus radius ulna joint. Humerus and the ulna, that is humero-ulnar joint, is the stellar joint, and the humero-radial joint is the modified ovoid joint. So all the three components of it are mentioned so far same joint capsule. So these may respond to the difficulty to trauma, exercise and massage and etc. So it has a capsule which is reinforced laterally by the radial collateral ligament and medially by the ulnar collateral ligament. So the annular ligament holds the head of the radius in its position. The annual ligament play an important role to hold the head of the radius in position. It flexes mainly due to the action of the biceps and the brachialis and the pronator teres and the common flexion. So it extends due to the action of the triceps and aided by the accumbens and common extensions. So the biceps and the supinator help it to supinate and pronator teres and the quadratus which help to pronate. So these important nerves of the upper limb pass through it are the radial nerve which is crosses laterally, the ulnar nerve which passes beneath the medial epicondyle and enter the forearm through the flexure carpi ulnaris. Then the medial nerve crosses in front. Then the interesting fact is that what is the patella cubitis? So these are the accessory bones present in the triceps near its attachment at the olecranon. It is called as the patella cubitis. Remember. Then the vital facts are primary elbow flexure is the brachialis and it is called the workhorse of the elbow flexion. Primary elbow extensions are triceps. So primary elbow flexures are brachialis and extension is triceps. So this is the anatomical view of the elbow joint. Posterior, medial and the medial view in extension. Then posterior elbow geometry. So, CM, CRMTOL, it helps to remember the secondary centers of ossification around the elbow, all the multiples of 2. So here is capitulum appear at 2 years, that is 6 months to 2 years. Then radial head, that is 4 years, medial epicondyle 6 years, trochlea 8 years, olecranon 8 to 10 years, lateral epicondyle about 12 years, internal epicondyle appears at 6 years, and trochlea appears at 9 years. So there is the external epicondyle appear at 12 years. And note the importance of these secondary ossification centers is that they are often mistaken as fractures in the children. Then triangle sign shows that a relation between the three bony points around the elbow, namely the lateral epicondyle, medial epicondyle, and the olecranon, is the important to differentiate between fractures around the elbow and the dislocation. So, in the flexion, these three bony points almost form an equilateral triangle, and this is main in supracondylar fracture and is the secondary centers of the ossifications are firstly, this is one is the medial epicondyle, second that is trochlea, third that is olecranon, fourth that is lateral epicondyle, fifth is capitulum, and sixth that is the radial head. And this is a diagram of the relationship between the three bony points of the elbow in flexion and extension between the lateral and the olecranon epicondyle and the medial epicondyle. So this is a triangle by three bony points: lateral epicondyle, medial epicondyle, and the olecranon. And is disturbs in the posterior dislocation of the elbow. In extension, these three bony points lie in the same straight line normally. In the posterior dislocation of the elbow and the olecranon process of the ulna, which is lie above the line joining the medial and the lateral epicondyle. So, carrying angle shows that these varies with the elbow flexion and extension. In full flexion, and carrying angle is 0 degree. So, in full extension of the elbow, the long axis of the arm and the long axis of the forearm do not lie in the same straight line, and the latter form a valgus angle of 11 degree with the former. And this is slightly more in the female and is called the carrying angle in extension. The carrying angle helps the elbow to clear the pelvis. An increase in this angle which result in cubitus valgus deformity, and decrease in the angle form the cubitus varus deformity. So however, the carrying angle disappears with the full flexion of the elbow, and it is in this position that the long axis of the forearm and the long axis of the arm lie parallel to each other. Then injuries around the elbow. So fall on the outstretched hand is more common in children because they are more playful and hence more prone to fall. So thus upper extremities are vulnerable to fractures, and 69 to 79% of all fractures sustained by the children are seen in the upper limb. So this is a carrying angle of the elbow. Here, one, this is normal. Two, that is this is increases, that is cubital minus. And three, that is decreases, that is in cubitus max. So this is a carrying angle of the elbow. And this is the diagram of the supracondylar area in the children. Just below, just above the condyle. So it is called as the supracondylar area. So in this table, you can see that incidence of injury around the elbow are injuries, that is supracondylar fractures, are 65.4%. Condylar is below that, it is 25.3. Fracture neck radius is 4.7. Monteggia fracture is 2.2. Olecranon fracture is 1.6. T condylar fractures are zero point 0.8, and in children, forearm bone fractures ranks first, which is followed by the fractures around the elbow region, and the incidence of the distal humeral fracture is as follows. That is supracondylar 69, lateral condyle 16.8, medial condyle 14.1, and T condylar, that is 1. Then the classification of the humerus of distal humerus, classification fracture of distal humerus in the children. In that, first is the supracondylar. Supracondylar, in that there is a flexion type, then extension type. B, that is physial fractures, in that involving the lateral condyle physis, then involving a medial condyle physis, involving a total distal physis, then involving a medial epicondylar physis, then involving a lateral epicondylar physis, and C, that is T condylar fracture. So first is the supracondylar fracture. So this is the area of the supracondylar fractures which are commonly seen in this area in children. The supracondylar fracture, as mentioned earlier, supracondylar fracture of the humerus is very common in the children. The reason lies in the bony architecture of the supracondylar area in children, the mechanism of injury and the predisposing factor exploit this potential weakness in this area and break it more often than any other bone in children. So, there is a supracondylar fracture of the humerus is also called as the Malgaian fracture. So, vital fact of pathological anatomy is why it is common in children in less than 10 years, because bony architecture at the supracondylar region is weak and vulnerable because in this region. So bone is remodeling, it is less cylindrical, metaphysis is just distal to two forces, Coronal and radial. Here the cortex is thin. Anterior cortex has a defect in the area of coronal fossa. Laxity of ligament permits the hyperextension at the elbow. Then important facts are predisposing factors for juvenile supracondylar fractures are ligamentous laxity at the elbow lead to the hyperextension. This hyperextension converts the linear force into the bending force, and oligonon which concentrate this force to the weak supracondylar area. And anterior capsule is top. So bony architecture of the supracondylar area. So in this diagram you can see the fall on outstretched hand is a common mechanism of the upper limb fractures in the children. And here in diagram A you can see this is the type of supracondylar fracture. Here is the extension type, that is 97.7%, and this is the flexion type, that it is only 2.3%. The mechanism of injury shows that fall on the outstretched hand with hyperextension at the elbow with abduction or adduction with the hand which is dorsiflex. So here in this diagram you can see a fallen ostrich hand with hyperextension at the elbow with the abduction or adduction with the hand dorsiflex. So here is the fracture of the supracondylar. The statistics gives the review that age first decade 5 to 8 year 84% cases less than 10 year. In boys, it is 63.6%, sides left 58.6, right 42.4, open fracture 2.3, nerve injury 7, that is radial nerve 45%, medial nerve 32%, and the ulnar nerve is 23%. VIC, that is 0.5%, fracture of ipsilateral extremity, that is 1.2%, and the phlegium type, that is 2.3%, and extension type is 97.7%. Then the classification shows that supracondylar fracture is broadly classified into the two types. That is, first is extension type and the flexion type. In the extension type, the fracture lines run upward and backward, and in the flexion type, it runs downward and forward. So, extension type supracondylar fracture is further classified into the following subtypes. Here is Gratland's classification in the children, in which type 1 shows undisplaced and type 2 shows displaced but posterior cortex is intact. So here in this diagram, you can see the type of the supracondylar fracture, that is A, is the extension type, that is 97.7%. And here is a flexion type, that is 2.3%. And this is the extension type of the supracondylar fracture which causing a neurovascular injury. Type 3, that is displaced but no intact posterior cortex, and the distal fragment could be either displaced. A, that is posteromedially, or B, that is posterolateral. So clinical features shows that the patient complained of pain and swelling which is gross. S-shaped deformity of the upper arm is obvious, and there is a loss of both active and passive movement of the elbow. So symptoms relating to the vascular and nerve injury may be seen. The patient may be also complain of pseudo paralysis, and tests should be carried out for brachial artery and all the three nerves of the upper limb, namely the radial nerve and the medial nerve and the ulnar nerve. So there is the injury to the any nerve out of this. The following are the characteristic clinical signs in the supracondylar fractures. That is, here is the arm is short and forearm is normal in length. Then gross swelling and tenderness. Crepitus is present but should be elicited for fear of increasing the pain and damaging the neighboring neurovascular structure. So there is a S-shaped deformity, dimple sign due to one of the spike of the proximal fragment penetrating the muscles and tethering the skin. So relationship between the three bony points is mentioned. Soft spots in an effusion beneath the accuneus muscles and movement of the elbow, both active and passive, are decreased. So X-ray of elbow shows a proper study of radiological sign in both AP and the lateral view. That is, here you can see in this X-ray that normal lateral view of the elbow. This is the elbow joint. It is normal lateral view of elbow joint. And this radiograph showing the extension type of the supracondylar fracture, that is in AP view. Okay. So a proper study of radiological signs in both AP and lateral view of elbow is extremely important, not only to study the fracture anatomy but also to check the adequacy and the accuracy of the reduction and the failure of which result in the malunion. So, in the AP view, the following are the radiological parameters are important in this view. That is, Bowman's angle between the horizontal line of the elbow and the line drawn through the lateral epiphysis and long axis of the arm. So, normally it is less than 5 degrees and should always be compared with the other side. So here the Bowman's angle, that is, line is drawn of the elbow and the line drawn through the lateral epiphysis, so which is less than 5 degrees. Angle between the long axis of the humerus and transverse axis of elbow is 90 degrees. That this one, this angle. At long axis of the humerus and the transverse axis of the elbow is 90 degrees. So less than 90 degrees suggests a cubital varus and greater than 90 degrees suggests a cubital varus. That is, we was studied in the before that, in the previous that. Then the lateral view. Lateral view shows a teardrop sign. That is, it is disturbed in supracondylar fracture and it is seen in normal radiogram. So normally there is an angulation of 40 degree between long axis of the humerus and long axis of the lateral epiphysis. Anterior humeral line, it is a line which is drawn along the anterior border of the distal humerus shaft, which passes through the middle one-third of the capitulum. So if it passes through the anterior one-third, then it indicates a posterior displacement of the distal fragment. Then a choroid line, which is a line directed proximally along the anterior border of the coronary process of the ulna, which is should just barely touch the anterior portion of the lateral condyle. And the posterior displacement of the lateral condyle will project the ossification center posterior to this line. So, This is a diagram of X-ray which shows extension type of the supracondylar fractures. This is the supracondylar fracture extension type lateral view. Then this is the look of this important landmark of lateral view of the elbow in the X-ray. That is first is the tear drop sign here in diagram A. That this is a tear drop sign. Then anterior humeral line. So this is a anterior humeral line. That is this one along the humerus. Then coronal line. That this one. And this is the relationship between the axis of the humerus and that of the lateral epicondyl. So in diagram D, you can see this. Then fat pad sign. Olecranon fossa is deep and thus a fat pad here lies totally contained within the fossa. So which is not seen on the normal lateral radiograph of the elbow at 90 degrees. But distension of the capsule with an effusion due to the trauma or infection causes the olecranon pad is to be visualized as a radiolucent gap. Then a fish tail sign that due to the rotation of the distal fragment, the anterior border of the proximal fragment look like a sharp spine. So it is called as the fish tail. Then a crescent sign that here the normal radiolucent gap of the elbow joint is missing and the crescent shaped shadow should due to the overlap of the capitulum over the olecranon is evident and indicate either varus or valgus tilt of the distal fragment. So this is a crescent sign. There is a pad sign, fish tail sign, crescent sign. Then quick facts are radiological point that posterior displacement of the distal fragment which indicated by loss of the teardrop sign, coronal line, fat pad sign and anterior humeral line. So coronal tail of the distal fragment which usually varus tail, rarely valgus, indicated on radiography by the crescent sign and the Bowman's angle. The horizontal rotation of the distal fragment, which is indicated by the fish tail sign. So, this is a diagram of the management, that is conservative treatment, that is initially a closed reduction tried under the general anesthesia by the traction and counter traction method, that is this one. So, here we stop and today we stop here our lecture. So once again, happy new year to all. Thank you.